Good evening, I am Dr. Shalmia from Department of Ophthalmology, Amrita Institute of Medical Science. I am second year PG.
I am Dr. Rehna, I am consultant in ophthalmology.
Today I am going to present a case of a 59-year-old female hailing from Alappuzha. Her presenting complaints were complaints of redness, swelling, pain, blurring of vision in right eye for 3 days. History of presenting complaints: 59-year-old lady with no known comorbidity developed fever 5 days back associated with chills and rigor. She developed redness and pain in right eye. 2 days later, it was associated with swelling around the eyes and whitish discharge with matting of eyelashes. She tried closing her eyes alternatively and found out that she was only able to perceive light with her right eye. She consulted a local hospital and was given some topical medications and was referred to Amrita for further management. No history of trauma, flashes or floaters. Past ocular history uneventful. Drug history: instilling homide, nepafinac eye drops, moxifloxacin eye drops, predacetate eye drops since 3 days. On general examination, moderately built and nourished, conscious, oriented in time, place person, cooperative for examination, no pallor, icterus, cyanosis, clubbing, lymph node enlargement, pedal edema, pulse rate 67 beats per minute, BP 110/70 mmHg. Systemic examination: CVS normal, S1, S2, CNS normal, respiratory system bilateral normal, vesicular breath sounds. Ocular examination: normal head posture, no facial asymmetry. Vision in her right eye was HM, hand movements close to face, left eye was 6/6, IOP digitally normal both eyes. EOM, right eye all movements were limited, left eye was normal. Now moving on to anterior segment examination. In right eye, eyelids, swelling around the eyelids with redness and local rise of temperature, mechanical ptosis present, eyelashes, matting of eyelashes present. Conjunctiva, there was congestion, chemosis and discharge. Cornea was hazy. There was hypopyon in anterior chamber in right eye. Iris normal color and pattern. Pupil was pharmacologically dilated. Lens hazy view. Left eye was normal. Dilated front examination. Right eye vitritis grade 4 plus. Left eye disc and macula normal. Vessels and periphery normal. So, our provisional diagnosis was endogenous endophthalmitis.
Why did you come to the diagnosis endogenous endophthalmitis?
Because she had history of fever and with associated with chills and rigor. So, mostly she could have developed a UTA or something which could have
history of infection in the body.
Then on anterior segment examination, there was redness, chemosis, discharge, hypopyon.
What is hypopyon?
It is collection of
inflammatory cells
in
the anterior chamber. It's a feature of endophthalmitis, it's a feature of uveitis too. So it could be like a very severe uveitis can also present like that, but in a scenario like this, when they had a previous infection in the body with this type of presentation, we cannot wait until to know what the diagnosis is, to get the sample and then know the results. We should treat it as endogenous endophthalmitis, because any delay in treating, the patient will lose the eye. What do you mean by vitritis? Vitritis, you said vitritis, right?
Yeah, there is intense inflammation in the vitreous. Vitreous is a liquid inside the eye.
Yeah, it is intense vitreous cells in the vitreous which is causing that hazy view. She said there is no view of the fundus. The other eye is having good view. This eye didn't have anything which we could see, like the disc vessels, nothing could be seen. That's because of those inflammatory cells in the vitreous. That's one of the feature of endophthalmitis.
On lab, CRP 88.72, urine routine, there was numerous pustules. Blood culture, there was no growth. In urine culture, there was no growth. MRI brain with contrast, there was focal meningeal enhancing dural based nodule noted in right basifrontal region, diffuse thickening of right ocular wall with associated post-contrast enhancement and adjacent fat inflammation, edema, soft tissue thickening along the preseptal region, mild thickening and enhancement of right optic nerve in the retrobulbar region in the intracorneal portion, suggestive of optic neuritis.
What does that mean, those changes in the MRI?
Panophthalmitis?
Yeah, because there is diffuse thickening with adjacent fat inflammation, which means kind of the it going into panophthalmitis. Endogenous inner cords are involved. When the sclera is also involved, is panophthalmitis, the whole of the globe. Then what does that mean by focal meningeal enhancing?
Neural involvement
is also there. So you were suspecting meningitis as well? Okay.
optic neuritis.
Optic neuritis, that is part of the scleral inflammation and the orbit involvement, which can cause inflammation of the optic nerve as well.
Now, what is endophthalmitis? Endophthalmitis is defined as an inflammation of the inner cords of the eye resulting from intraocular colonization of the infectious agents with exudation within the intraocular fluids. It is potentially a blinding condition.
It's one of the ophthalmic emergencies. We have only a few ophthalmic emergencies which has to be treated very quickly. Like one is endogenous endophthalmitis, the other one is trauma. Then we have something like acute congestive glaucoma, then retrobulbar hemorrhage. These are some of the things where you have to act fast, either to save the vision or save the eye.
Based on the mode of entry of the organism, it is divided into exogenous and endogenous. Depending on the causative event, the exogenous endophthalmitis can be either post-traumatic or post-operative. Endophthalmitis is one of the most serious ophthalmic emergency which require urgent medical attention and treatment to save the vision or to salvage the integrity of the eye.
So exogenous means whenever it is coming from outside, most of the time post-operative, like post-cataract, post-intravitreal injections, that is mainly the exogenous. Then trauma is also there when it's coming up from outside. But endogenous means it's something in the body or infection in somewhere else in the body which is spreading via the blood to the eye. Eye actually have a blood retinal barrier just like the brain. So usually it's kind of protected, but when there is inflammation it can be broken and organisms can get into the eye.
Etiology: in case of post-traumatic endophthalmitis, staphylococci and Bacillus cereus are the most common isolates. Acute post-operative endophthalmitis within 6 weeks of surgery results more commonly due to contamination of the intraocular structures with normal bacterial flora of the adnexa such as Staphylococcus epidermidis. Delayed or chronic post-cataract surgery endophthalmitis after 6 weeks of surgery. The common causative organism is usually bacterial, most commonly Propionibacterium acnes, followed by Kyglis negative Staphylococcus, though fungal infections including Aspergillus, Candida and others can also occur. In case of delayed onset endophthalmitis associated with BLEP, trabeculectomy, glaucoma, drainage implants, Streptococci species and Haemophilus are the predominant culture isolates. Most cases of endogenous endophthalmitis are secondary to fungemia, predominantly Candida species. Among bacterial causes, Staphylococci species predominate in the western population, and among the East Asian population, Klebsiella pneumonia predominates. Pseudomonas in a virulent and aggressive organism can also cause endogenous endophthalmitis.
Yeah, in our sector, when we did the study, we found that the bacteria and fungus are almost the same, equally. We found both the same proportion, like 50% bacteria, like that when we did the study on all the patients. But previous Western countries and all, it's a fungus, which is mainly in the endogenous endophthalmitis. How do you differentiate between fungal and bacterial endogenous endophthalmitis?
Bacterial will be a more rapid course, whereas fungal is an indolent course. It will take time and will progress.
Yeah.
In bacterial there will be intense vitritis, retinitis,
intense inflammation. Even from the early stages, severe inflammation, vitritis, you cannot see the fundus like that. But in bacteria, fungus, it will be like localized vitritis, snowballs in candida and all. It's kind of very slow progressive course, not very slow course compared to bacteria.
So in history, first you should ask about the inciting event. You should ask about surgery, trauma, contiguous spread keratitis, endogenous endophthalmitis or other procedures. Onset, fulminant, acute and chronic. Most of the cases of fulminant endophthalmitis are caused by highly virulent organisms such as Pseudomonas aeruginosa, Bacillus species. The rapidity of progression, rapid or gradual. Bacterial endophthalmitis progress faster than fungal endophthalmitis. Systemic illness, history of intravenous infusion, prolonged hospitalization, diabetes, renal or liver problems, helps to localize any source of endogenous endophthalmitis, calibrating the drug dosage.
Yeah, that is important. Any patients who are like immunosuppressed, when they are saying of any even a slight redness in the eye, it's better to rule out endogenous endophthalmitis.
So
we can actually shine light in the eye. Doesn't actually require indirect, at least minimal. And if you could see that line with hypopyon, it will appear as a white line. Have you seen this patient? Hypopyon was there, right? Like that. If you see, it's most probably it would be endogenous. But if in doubt, definitely it has to be have a fundus examination.
Ophthalmic assessment, visual acuity including projection of rays. When visual acuity is less than counting fingers, EVS standard help in the maintenance of uniform records after occluding the better eye with light directed from behind the patient. Hand movements are tested at a distance of 60 cm. Perception of light is tested at a distance of 90 cm with the bright light of indirect ophthalmoscope. At least 4 out of 5 responses should be correct reading to be considered. Now, examination of the ocular adnexa, especially to look for severe blepharitis, meibomitis, stye, chronic dacryocystitis cystitis and other sources of infection. Then ocular movements, reduced or absent ocular movements in case of an endophthalmitis with proptosis and pain clinically point to the diagnosis of panophthalmitis. Anterior segment examination, close focus at the site of entry, SIC, small incision cataract surgery, tunnel, corneal entry wound, blood, perforating trauma, look for corneal clarity, corneal infiltrate, posterior capsular plaque, vitreous in the wound, open wound, unsutured wound and hypopyon, fibrin, posterior synechiae, etc. Now, intraocular pressure also should be looked for. Then fundus examination, if media permits, look for any specific pattern as well as mimics such drop, lens matter, intraocular, foreign body and all, we should look for the fundus. Now, ocular sampling, we can take anterior vitreous tap as well as vitreous tap or biopsy.
Tap means we take with needle. The bedside we can do it. You would have seen us doing it, right? With the needle injected, it would be around 4 mm from the limbus. It would be actually introduced into the vitreous and then it will be aspirated. So, but the problem is that when you're doing it, there is some kind of traction on the vitreous. So, that is a problem. So, we can do vitreous biopsy where the patient has to be taken to the theatre and with that vitreous cutter it has to be taken. So, it is less traumatic for the vitreous, no traction will be there. But most of the cases the patients will be sick in endogenous endophthalmitis and we would be able to do only tap.
Now, in systemic assessment, look for signs of septicemia like fever, elevated ESR, blood culture in case of endogenous endophthalmitis, blood test, hemogram, renal and liver function test, look for drug toxicity, search for the focus of infection in endogenous.
That's why we always refer to the infectious department, because definitely there is some source of infection in the body and that has to be looked in and that has to be treated as well. Intravitreally we are giving the antibiotics because the systemic antibiotics which are given may not have a good intraocular penetration in the eye. So, intravitreal has to be given to have the effect in the eye, but at the same time the systemic has to be treated as well.
Endophthalmitis is a true ophthalmic emergency and requires appropriate and prompt therapy. The main objective in endophthalmitis treatment are to eradicate or control infection, management of inflammation, supportive therapy. To eradicate or control infection, the use of systemic antibiotics in the setting of exogenous endophthalmitis is controversial as most of the drugs given have poor intraocular penetration. The best documented drugs achieving therapeutic levels in vitreous are 4th generation fluoroquinolones, meropenem and linezolid.
Basically, moxifloxacin is having a good penetration.
In endogenous endophthalmitis, systemic antimicrobials in conjunction with intravitreal antimicrobials reduce the rate of evisceration or enucleation. Local antibiotics you can give. A combination of two drugs is preferred during the initial presentation, one having a potent gram-positive organism and another on gram-negative organism. Then intravitreal injections you can give. The intravitreal route of drug administration helps in achieving high concentration of drug in the vitreous cavity without associated systemic side effects. Two broad spectrum antibiotics are chosen initially. EVS study utilized intravitreal vancomycin and amikacin. However, due to higher retinotoxic potential amikacin, it has now been superseded by ceftazidime.
This is the usual one which we give. Like if we feel that it's a bacterial only, we just give vancomycin and amikacin. Vancomycin is supposed to cover most of the organism which causes endophthalmitis. Then ceftazidime for gram negative. That's the usual one which we are giving initially. Then if we have a suspicion of fungal as well, we add voriconazole along with it. So it will be 3 drugs which will be given. We are taking the vitreous, right? So we can fill it with these 3.
Vitrectomy has several advantages over conservative therapy. Vitrectomy improves retinal oxygenation, reduces the inflammatory load within the eye, provides specimens for diagnostic evaluation, allows direct inspection of the retina, allows definite treatment, reduces the load of infection, reduces the severity of the disease and accelerates visual rehabilitation. Supportive therapy, we can give cycloplegic agents like homatropin 2%, atropine 1% in an essential part of the treatment that relieves the ciliary spasm and prevents synechial formation. In patients with elevated intraocular pressure, oral and topical medications need to be added. Vitreous tab before intravitreal injection also reduces the intraocular pressure. Hypertonic saline 5% drop or 6% ointment may be needed in cases of severe corneal edema. Now DEDs, one is TAS.
That is only for post-surgical, right? We can skip that.
Post-surgical. Non-surgical endophthalmitis could be chronic uveitis, retained intraocular foreign body, old vitreous hemorrhage, toxoplasma retinochoroiditis, necrotic retinoblastoma, acute retinal necrosis, severe pan-uveitis, intravitreal cysticercus with intraocular inflammation.
These are some of the conditions which mimic like that, like with the hypopyon, with the inflammatory cells, and all can sometimes be due to all these conditions.
Now prognosis. Nature of endophthalmitis. Better visual acuity has been reported in cases with culture negative post-surgical endophthalmitis. Bleb associated endophthalmitis carries a poor visual prognosis. Endogenous bacterial and fungal endophthalmitis also carries a poor visual prognosis. Organism endophthalmitis due to Streptococcus, Bacillus, Pseudomonas and Candida carry poor visual prognosis. Presenting visual acuity. In the EVS study, it has been noted that presenting visual acuity remains more powerful than microbiological factors in predicting the visual outcome and response to vitrectomy.
Basically, if it is a severe vitritis, if there is a very poor vision presentation, if it is a bilateral presentation, patient is very sick, all these are conditions, factors which has a bad prognosis on vision and on life.
Time to initiation of appropriate therapy is one of the prognostic factor. It is of utmost importance in case of post-traumatic endophthalmitis, especially with Bacillus species. In the EVS study in the group with a vision of light perception only, early vitrectomy resulted in a 3-fold increased chance to achieve greater than 20/40 and 2-fold increased chance to achieve more than 20/100 and was less likely to worsen less than 5/200. Systemic stability of the patient. Immunocompromised patients with endogenous endophthalmitis have concurrent polymicrobial infection which influence the final outcome. Thank you.
So any patient, whenever we see sick patients with any symptoms in the eyes like blurry vision, redness or hypopyon, they should have an evaluation for endogenous endophthalmitis, endophthalmitis. And if endophthalmitis is diagnosed, prompt treatment with one vitreous biopsy and intravitreal antibiotics, antifungals has to be given. And like this patient who had a very bad vision at presentation, which is hand movements, means he can just see the hand moving. In such cases, early vitrectomy has to be done. Early vitrectomy followed by antibiotics into the eye. And regarding the systemic antibiotics, we always leave it to the infectious department to decide, because it depends upon what kind of infection the patient is having. Usually what we have seen is that they get a coverage with both gram positive, gram negative, piptas, strong antibiotics or meropenem is given. and they have to be given for 7 to 10 days intravenously, and usually oral antibiotics continued for 4 to 6 weeks. And regarding the intravitreal antibiotics, if it is responding nicely, we do repeat at 48 to 72 hours. If there is deterioration, if vitrectomy has not been done, we go for vitrectomy, and depending upon the response, we may repeat like twice a week, but there is nothing, no protocol regarding it. According to the patient, we would do. It's regarding the endogenous, it's combined treatment, it is given.